Salamet sizbi, kürmettük, körörmender, men spikeler. Добро пожаловать на наше 12-е ток-шоу «Давайте поговорим о первичной медико-санитарной помощи». Серия наш ток-шоу привлекала 4000 зрителей из более чем 40 стран с его начала. Это свидетельство того, что есть большой интерес к обсуждению о политике первичной медико-санитарной помощи. Сегодня наше ток-шоу совершенно особое. Мы ведем трансляцию из прекрасного города Тюркистана на юге Казахстана с богатой историей и традициями. Мы собрались сегодня именно здесь, так наше ток-шоу впервые проводится в контексте Совета по сотрудничеству в области здравоохранения Содружества независимых государств СНГ. Я имею честь приветствовать глава делегации из 7 стран СНГ, 5 со мной в студию и 2 страны онлайн. Они участвовали в работе Совета. И нашего регионального директора, доктора Ханса Kluge. У вас был очень насыщенный график, я думаю, сегодня. Спасибо огромное, что нашли время и соединиться с нами, поговорить 1 час. Совет обсудил очень много тем по развитию здравоохранения в странах СНГ, очень много инициатив. Но согласитесь со мной, что существует консенсус, что успех всех новых инициатив зависит от медицинских работников. Они наше главное сокровище. Но в то же время кадровая политика является самой сложной задачей нашего времени. Как привлечь медицинских работников в сельские и труднодоступные места? Способны ли цифровые технологии, о которых мы столько говорим эти дни, содействовать работе медицинского персонала? Или это дополнительное бремя? Как создать мотивирующую среду работы и предотвратить эмоциональное выгорание? Как стимулировать профессиональный рост? Эти вопросы находятся в центре нашего сегодняшнего разговора. Для первого выступления большая честь представить того, кто не нуждается в представлении, директора Европейского бюро здравоохранения доктора Ханса Kluge. Доктор Kluge, всего 1 неделя прошло с регионального комитета в Израиле, правильно? И там кадровая политика тоже занимала очень высокое место на повестке дня. Какие были основные результаты обсуждения?
Спасибо вам большое, глубоко уважаемый Рита. Для меня очень большая честь с вами сегодня и с министрами. Это уникальная возможность. Правда, все страны Европейского региона ВОС, включая СНГ, сталкиваются с критическими кадровыми проблемами. На прошлый день, как вы сказали, уже региональный комитет ВОС в Израиле уделил огромное внимание этой теме с участием делегаций самого высокого уровня из 53 стран. И были проведены 2 очень важные сессии. На первой сессии был представлен наш новый обзор кадров здравоохранения в Европе «Время действовать». И теперь у нас есть более полная картина рабочей силы региона. Есть нехватка персонала, разрыв между Востоком и Западом, стресс и эмоциональное выгорание, но также на решения, такие как приоритизация психического здоровья и повышение квалификации. Поэтому я с нетерпением жду нашей дискуссии о ваших успехах в преодолении трудностей, с которыми сталкиваются работники здравоохранения, чтобы мы могли вдохновлять друг друга. И это подводит меня к второй важной встрече, которая состоялась в региональном комитете. Встреча главных медсестр. Наши медсестры и акушерки играют все большую роль в предоставлении услуг, формировании новой организационной культуры и политики. Особенно это касается первичной медико-санитарной помощи. Год назад мы создали платформу ВОС для обмена знаниями для медсестер и акушерок. Центр главных медсестер и акушерок стран. Сейчас 37 стран, и из них 6 стран СНГ. Я очень горжусь об этом. Сету регулярно проводятся встречи для обмена опытом старших медсестер и акушерок, лидеров по формированию политики в области образования, человеческих ресурсов, гигиены труда для работников и организации предоставления услуг. И встреча сети по обе стороны от регионального комитета подтвердили важность расширения прав и возможностей медсестер и акушерок. И я с нетерпением жду от вас на этом круглом столе опыта в вашей стране, как вы делаете то же самое в вашем контексте.
Спасибо, действительно, очень важное решение и обсуждение. Давайте остановимся немножко на сельское здравоохранение. И наша принимающая страна, Казахстан, уделяет огромное внимание развитию ПМСП на сельских местах. Большая честь представить министра здравоохранения Казахстана, доктор Ажар Геният. И я думаю, я могу раскрыть для всех, что сегодняшний ток-шоу это была ваша идея, потому что вы всегда с энтузиазмом говорите о важности инвестировать в ПМСП, и в ПМСП особенно в сельских местах. Какими успехами может Казахстан делиться с другими странами для вдохновления, как Ханс говорил?
Көп рахмет, Мелита Яков. Мы очень благодарны, что вы сегодня поддержали нас и организовали такое ток-шоу. И не только Казахстан будет говорить о своих успехах, но и мои коллеги из стран независимых государств. И думаю, нам будет это очень интересно. Но мы все знаем, что кадры решают все. И очень в медицине можно построить современные больницы, оснастить хорошим оборудованием, но если кадров нету или недостаточно квалификации, достаточно качественной медицинской помощи оказывать мы не можем. А сегодня это очень важный вопрос, который перед всеми нами и главы государства, и правительство ставят, чтобы мы обеспечили качественную, доступную медицинскую помощь. По сельскому здравоохранению у нас в стране по развитию и модернизации сельского здравоохранения на сегодняшний день вопрос ставится на уровне главы государства. По последним посланиям он поручил правительству, Министерству здравоохранения модернизировать, обеспечить качественной медицинской помощи именно сельчан. И вот этот дисбаланс уменьшить между получением медпомощи между сельским и городским населением. У нас в Казахстане сегодня 41% населения живут на селе. И чтобы удержать кадров, и чтобы молодые специалисты туда на село поехали, конечно, мы на законодательном уровне в первую очередь работаем, чтобы повышать им заработную плату.
Try to increase their salary. The rural medical workers are getting additional funds for working in the rural areas. And then they're also being provided with these special funds. We call them kind of startup funds. So on a legislative level, we've provided for these startup funds in the budget, so it's additional money for the beginning. But apart from that, every Akim in the region, the regional mayors also allocate budget to recruit quality doctors to the rural hospitals. There's also housing being provided for them to be able to as just social support housing for the specialists that are coming in, or loans with no interest rate for them to be able to buy their own housing there. So that's the social support. Another thing I'd like to point out is that for primary health care, we've implemented a multidisciplinary, multi-layered or multi-profile medical service system. So it's not only medical, but also medical and psychological service. The doctors are now helped in rural areas, but by not just one nurse, but one doctor has up to 3 nurses. And in the doctor's team, you also have a counselor and a social worker. That's in the healthcare system. In our social protection, we also have social workers, but in the healthcare system, the social workers are especially trained to work with the doctor and see what problems the patient might have, to also render the counseling support, and they have connections with the social protection authorities to see what they can do to, as much as possible, help out the patient. And we'd like to also thank you, of course, Mr. Hans Kluge, for you having supported us in opening in Kazakhstan in the Yenbekshi Kazakh region, in the Almaty region. Now the whole world knows that. The town of Issyk, the first demonstration platform for primary health care. And my colleagues come there and we share experience. And our model shows that the burden on the doctor is reduced using this new method, and the population really have this need for these psychological services. In the post-pandemic period, that's become evident in this new technology of ours. We see that we have to keep developing a rural healthcare. There's a big program out there. There's a national project being adopted right now at the government level, where we want to, in the brief 2 years, provide new outpatient services, as well as inter-district hospitals, in order to improve specialized help, medical assistance, and urgent medical assistance, emergency. So I'd like to thank all my colleagues, the ministers of healthcare of the CIS states, the ministers for you having accepted Kazakhstan's invitation, and today at the council we're discussing some very important issues. And I think today we will discuss a lot of these issues. Yes. In the first delegation is from Uzbekistan. Uzbekistan is also promoting some large-scale reforms, and it's a big honor for me to introduce Minister Begzad Musayev, the Minister of Health of Uzbekistan. Now, Mr. Musayev, you're an economist, and you have a unique view on these things, because you listened about financial motivation, but also non-material motivation for the healthcare workers. What instruments of motivation or incentivization do you use in order to improve the attractiveness in rural areas of primary healthcare?
Thank you very much. First of all, it's a great pleasure for me to participate in such a talk show and to hear the experience of our colleagues from Kazakhstan. If you allow me, I first would like to share the experience of Uzbekistan in the field of supporting PHC, motivating the medical workforce. As you know, the president of Uzbekistan, out of 9 key strategic goals that he sets for the medium term, one of the areas, and for us it's a huge honor to know and be a part of, is the development of healthcare system. What do we mean by development? First of all, accessibility of healthcare system for all categories of the population. As we know, there is a principle of like one step towards WHO. In WHO, there is a certain principle. Some categories are indeed remote, living in villages, in the mountains. We have a huge territory in our country, and for 35 million people, it's impossible to urbanize all of the population. Therefore, we work very closely in order to improve accessibility for people to have 10 to 20 minutes access to healthcare, which requires a lot of construction costs for building the facilities. Here we have two pillars. First, provide accessibility, ensure accessibility of medical facilities, and secondly, they have to be supported with the workforce providing high-quality medical services. Out of these fields, in Uzbekistan, we have about 2,000 family polyclinics. In each district, there is a multi-profile central polyclinic. The head of the district healthcare system is the chief doctor of the multifaceted polyclinic, not the hospital. He is the head of the outpatient facility. The reason it's done is to support primary healthcare development. In order to improve accessibility, there are certain areas where accessibility of primary healthcare is about 25, in some cases 30 or 35 kilometers. And those areas are, of course, a priority, and we made a suggestion to the president, and he supported this idea to create small district medical points in Uzbekistan, similar to Kazakhstan and to Tajikistan and other Central Asian countries. There is the so-called collection grouping of citizens. We call them mahala. So the collection, the groups of populations. It is the president gives us a task that in each mahala there should be one medical facility. So we use very light constructions, low-cost constructions with the use of containers, and the Ministry of Healthcare, together with the Ministry of Construction, developed a standard facility construction. What do we need there? We need to provide the primary equipment, ensure access to internet, and to create 2 rooms where a doctor and a nurse can provide primary health care. So, and in this year, we have established, and until the end of the year, we will create 1,058 such medical facilities. We have 2,000 existing polyclinics, and additional 1,058 medical points will be created. Who will work there? President, in a special decree, assigned the medical teams. We have established 17.5 thousand medical teams. In them, in each team, there are 5 members: doctor, practicing nurses, 2 patronage nurse, and a midwife. So they provide, such teams provide primary health care. This primary health care has to provide midwifery services. And naturally, at the end of the day, all of these measures allow to bring closer to rural populations our primary health care. So for 3.5 million people, which is 10% of the population, is now closer to PHCs services. In order to supply these institutions with workforce, we asked people, what motivates people to become doctors and to work in rural areas? I would like to draw your attention to the fact, is financial motivation paramount to provide medical services in rural areas? And it's not. It turned out it's not. So those people working in remote areas, 55% of interviewees answered that the key interest for them is like interest in their profession. They want to be useful to the population, to the society. 13% of people answered that they have a family tradition that was formed by their parents. So children continue with the mission, the mandate of their parents. What conclusion do we come to? Medical personnel, people make this choice with awareness, understanding who they will be in the future. The next area that we would like to stress in this regard is the workforce in the primary healthcare. is based on 4 pillars. First, responsibility. Second pillar, the feeling, the commitment to the doctor's oath, and of course, the president of our country said that we have to. We understand that people love their profession and feel honored to help the people of Uzbekistan. Nevertheless, we need to provide financial incentives for such people because they choose their profession having non-financial incentives in mind. We need to provide for those doctors going to rural areas. First of all, the government has to identify what mahallas, the districts, are remote. They are identified first. Those doctors who work in such remote areas will provide extra financial incentives. What are those? Monthly $200 payments, irrespective of how long they will work. So they will receive $200 extra payment, and local budgets will meet 50% of the relocation costs. Those doctors who completed their medical school, and if they work for 3 years in remote areas, they will be studying for free under internship programs to support such workforce, and a separate government resolution was issued stating that students who choose the profession of family doctor will have the right to work during the 2 final years of their education. They will be working, practicing, but at the local level from where they came, the right district, village that they come from, they will be paid 100% of their salary from there, while they're still students. So these extreme measures are implemented in our country in order to ensure maximum accessibility for our population and to make sure that our medical workforce has incentives to go to closer to people, to remote areas. Besides that, the special sign will be introduced. In Uzbeki, it sounds differently, but we have the order, the keeper of people's health. It's an order given to doctors working in remote areas. We come to the conclusion that the KPI has to be taken into account as well for doctors. What criteria do we set to PhD doctors? As you may know, in Uzbekistan, one doctor, based on the standard, has to provide care to 2,000 individuals. The key criterion here is reduced extra weight. So we start with the inventory of all 2,000 people who have extra weight. The weight of those people is compared with the weight next year, but it's not just pure comparison. People need to be talked to that some extra weight is there. It can result in certain chronic diseases, and people need to know that they should walk more, at least 5,000 steps a day, etc., etc. So, absolutely right. Yes, they should eat less fat food, etc. The next principle is raising awareness about the healthy eating habits. So 3 to 5 vegetables a day, you will have less weight. Next indication is to increase physical activity. Doctors in mahallas may invite in the evening 50 ladies, and they will have like a sort of a mini marathon to walk. So people's awareness should be improved. They should understand that they shouldn't just eat and sleep, lie down without physical activity. So this explaining this work is done. They understand that lifestyle can lead to various chronic and various disease. So we do this analysis, and those people who achieve good results in this work will provide additional honors. They will get a special sign, the appreciation from the government. Those who didn't reach this KPI, we will not punish them, of course, but we will just provide incentives to those who work well, so that they could push others around them. And it's done on an annual basis. So in general, we can say these are the good experiments that we conduct. In PHC system, in Uzbekistan, more than 183 people work in PHC. It's hard to evaluate the KPI, effectiveness of each of those individuals, but this work has to start somewhere. It has to start somewhere in order to achieve progress. So we provide the incentives, we motivate the workers. We understood that moral values matter a lot in their work. And we want to support it with financial incentives as well, so that they could also be satisfied with their work with people and with their profession. Thank you very much for your attention. I think I spoke too long. It's very interesting, very interesting. So we see how complex this topic is, and it has to be approached from different sides. And I saw with my own eyes when I was in Sindarya Oblast this spring, I saw how in short period of time you achieved great results, and nurses worked with Mahalla, with the communities. It was great that their autonomy of decision-making improved. With this, I would like to give the floor to the neighboring country, Kyrgyzstan. Kyrgyzstan has... So, Kyrgyzstan was a champion in involving rural communities in improving health. Correct, right? So I'm very happy to introduce the Minister of Health of Kyrgyzstan, Ms. Gulnara Batira. First of all, I would like to congratulate you with your appointment. Kyrgyzstan is very lucky that you became the minister. You yourself worked in PHC system for many years, and you really are invested into this field. What are the measures of policy that can be implemented in order to improve the PHC workforce at the rural level? What are the specific results of those policies? Where do you see the greatest opportunities in both fields as a new Minister of Health? Thank you very much. Dear Mr. Hans Kluge, dear Ms. Melita, dear participants of the talk show, allow me to welcome you, to greet you at the talk show, and I would like to thank the Ministry of Health of the Republic of Kazakhstan, as well as the European Center of WHO on PHC for the adopted initiative to discuss such an important topic.
Protecting the health of Kyrgyzstan is all about early prevention, improving the availability of quality healthcare with a rational use of all the resources of the healthcare system. Due to primary healthcare reflecting progressivity and being a reflection of all the healthcare systems, starting 1996, Kyrgyzstan has taken a course to reform the system from the practice of providing expensive healthcare in hospital to outpatient. And as a result of the programs of reforming the systems of healthcare, we've achieved an improvement in our indicators of our performance. Now, personnel are one of the priority directions of the program on protecting the population of the Kyrgyz Republic until the year 2030. In the country, we especially focus on developing primary healthcare to provide access to quality healthcare services, specifically in the remote areas of the Republic. Currently in Kyrgyzstan, the general practitioners are one of the largest cohorts of doctors and amount to 2,195 doctors. We are still lacking 1,082 family doctors. In order to have the graduates from medical universities and doctors in the regions to retain them, the decrees of the government have announced measures of incentivizing the doctors and healthcare medical workers working in the rural and remote areas of the Kyrgyz Republic. They approved the program on additional incentivizing of doctors, those that work in healthcare institutions of remote areas, small towns, and rural areas. The program on incentivizing the young specialists is being implemented successfully and currently in the regions. Many graduates, as part of that program, get significant support from the state. As of today, there's 175 workers working in that program. And as part of this program, we're also solving the issues of staffing the remote healthcare institutions and rural area ones. But staff retention is still a big issue. And there are funds being budgeted for to do so. Now, to provide the staff, the ministries are allocating the medical staff that have finished their residency studies to these healthcare institutions. And there's about 250 places. 100 of those are for family doctors. And because family doctors are the priority specialty, the 1st of April of 2021, we improved the salary of family doctors by 100%. In the above program until 2030, we also have planned reforms of the nursing education, taking into account the new requirements of the healthcare. And when nursing's role has significantly increased, there was a need to delegate certain functions of the doctors and to create legal documents. Now, in order to improve the activity and work of nurses on primary health care level and to improve the quality of provided medical services to the population, we've developed and approved the new responsibilities of the family nurse, the professional standards and a competence catalog. Based on these documents, we've reviewed the responsibilities of the nurses. For instance, per 1,000 population, one nurse, and 200-something nurse visits per month. There's also a screening to detect non-viral diseases, non-communicable diseases. And to finalize, I'd like to thank the World Health Organization for their help in developing primary health care in the countries. Thank you very much for listening. Thank you very much, Ms. Gulnara. These are really big things that you decided to do to strengthen the personnel policy. So if we're talking about rural areas, then definitely we have to take into account the experience of the Russian Federation, because the Russian Federation has a breadth of experience in strengthening rural healthcare. There is a program, Zemsky Doctor, Zemsky Paramedic. So Dr. Yevgeny Kamkin, the Deputy Minister of Healthcare of Health of the Russian Federation. Mr. Yevgeny, from your experience, what are the programs that are the most effective, and what results were you able to achieve due to the implementation of these programs? How has this helped reduce the workload on the doctor? Good day, Dr. Kluge. dear Ms. Moderator, I'd like to first of all thank the Ministry of Health of Kazakhstan and the World Health Organization and the Executive Committee of the CIS for organizing this meeting today and today's broadcast on this high professional level. It was really interesting to listen to the reports today and the speeches. Some of these issues definitely demand further studying to borrow experience by our country too. So starting 2012, we've been implementing the Zemsky Doctor project. Starting 2018, a bit later, we started also with the Zemsky Paramedic. Now, rural healthcare is what we especially focus on. We don't have such a large number of population living in rural areas like Kazakhstan. It's about 26% living in rural areas in Russia, but the arrangement of healthcare in those areas is of high priority, and some federal projects that are being implemented as part of this big healthcare project are specifically devoted to arranging healthcare in the rural areas and improving its quality for them. As an example, the importance of the primary healthcare, I can give you two numbers. So in our country, we have about 147 million people, and annually the number of hospitalizations was about 30 million per year. And the number of visits to the primary chain was about 900 million. So it's a significant number, and the primary level is that specific field that the patients mostly contact with. They usually seek assistance there. And over the time of this program, we were able to attract the doctors to the rural areas, about 45,000 doctors, and the nurses, the paramedics, the midwives, about 6,500. Now, as I said, the program started at a different time. We provided for compensations, for payouts to the staff, and they amount to about 1 million rubles right now, which is equivalent to about $16,000 for doctors and $500,000 for the nurses. But as you know, our territory is diverse, and there are territories where life is more difficult. The Arctic areas, the northern regions, those payouts are twice as much as the other regions, the other territories. Now, apart from these payouts, the regions themselves have social support for the population, which also helps attract specialists to work in rural areas. That's creating the necessary housing conditions for different programs, loans with beneficial loans, and providing housing with the ability to, after several years, after the person has worked, to become the owner of said housing. Of course, it's also about creating the circumstances for not only the medical worker themselves, but also the family should be able to live comfortably, provide a job, help find a job for the spouse, a school for the children. That's also an important factor to retain the medical staff in the rural areas. The regions focus on that strongly as well. And it was already mentioned today, and we focus strongly on the digitization of healthcare and implementing digital technology. Currently, all of the outpatient institutions and the paramedics institutions, they all have internet access. That's also an ability for the nurses to get a consultation, to contact a second or third level healthcare institution if they need to consult a patient and make a decision on what to do with the patient, and get some advice and send a specialist. in order to, in more detail, figure out the case. That also, of course, influences the quality of the work of the medical staff in the rural areas. We're also planning, as part of the state guarantee program, to provide for measures that would improve the quality specifically of medical services. And it's been implemented starting this year. Payouts for quality of work, KPI-based. For the outpatient clinics, they have these additional payouts that per capita, and also additionally, if they comply with the KPIs, and for prevention as well. For preventive measures, maybe you've heard we're implementing a project for countering cancer. There are payouts for doctors and first-tier healthcare workers for detecting cancer at an early stage. Apart from this, another important thing is creating the necessary conditions. So see, the conditions in which the healthcare workers actually carry out their activities. They need to have good conditions there, a nice room they work with, good equipment, medical equipment that's in working order. It's best if this equipment is able to share data online. So for that, we have a special federal project which is called Modernizing the Primary Healthcare. And for that, we will be spending several billion rubles to buy new equipment and vehicles, which is also important for primary healthcare because not everybody has the opportunity or the ability to reach the medical institution on their own to travel. So the medical workers need to have an ability to visit the people at their homes. So we're doing that together with the Ministry of Trade, providing the vehicles for the healthcare workers for these specific purposes. So I suggest that this comprehensive approach to solving these tasks is what's going to help us bridge the largest gap. And the most important resource, of course, that we need most of all is the people. And that's specifically so in the rural areas. Yes, there's a lot of parallels, right? When we listen to parallels, there's a lot of parallels, things that we can learn from each other. But I'd like to provoke some discussion, right? If you allow me, Dr. Kluge.
Dr. Kluge, I approach you. We talk about building, about attracting workforce in rural areas, but is there another way in 21st century? In your program, in your speech in Israel, you use the word multi-platform. We have a debate within our team how to translate it better into Russian. Could you please talk about what is multi-platform delivery of services? How can it help us in improving access in 21st century? Yes, absolutely. As I said before, the pandemic taught us a lesson, how to improve access to healthcare services to all population. Thanks to face-to-face provision of services with the use of digital technology, a lot of you mentioned this, and provision of services by mobile teams as a preventive step. I see a lot of potential in the reasonable use of telemedicine in remote and rural areas. Small villages face difficulties in attracting healthcare workers. The main issue is not only finance. You, Minister, said it's not the only problem. Therefore, we know that young, educated people would like to be connected. They don't want to be in isolation. They do not want to live in isolation. It's a different time. Therefore, I believe that we need to better use solutions provided by the 21st century and to rely more on digitalization. Therefore, I'm so happy to see the launch of our second demonstration platform on PHC. As Ms. Ginayat, the minister said, you became the first platform. In this second platform, we will show the integrated digital technologies in rural and remote areas. This platform will be located in Västerbotten. Melita will be there together. It's in South Lapland. This is an area with a lot of remote rural villages. And the combination solution on the basis of the networks of PHC and digital technologies solve the problems of access to PHC for the citizens of any, even most remote settlements. I would like to invite the CIS countries to visit the demonstration platform of WHO. First, with you, Dr. Ginayat, we went there together. I'm sure that the practical example of our platforms will be very useful, not theoretical, but practical demonstration will allow to preserve medical workforce and to create inspiring environment for our workforce. It's great, very interesting. Every speech today, we talk, everyone mentions digitalization. It's not that easy though. We worked with you in Belarus, for example, on implementation of digital consultations, and it's not that easily accepted by people. There is always some resistance. I would like to present Ms. Tarasevich, who represents the Ministry of Health of the Republic of Belarus. What is your experience of providing digital consultations? So what is the view of such consultations by the medical workforce and the population? Thank you for this question. The head of state and the government of the Republic of Belarus pays attention to the quality and accessibility of healthcare services. We analyze on a day-to-day basis. We talk about various issues that we face, especially in the period of COVID pandemic. The situation was changing dramatically. The regulatory framework was changed. The tactics to refocus the beds, the new tactics were created when we talk about sporadic infections and when the rise of infection rates is experienced. So the tactics was adopted with the help of WHO. We worked together in the Republic of Belarus on the platform of 2 outpatient clinics. The pilot project was implemented on the basis of the resolution of the government to implement such a project, to establish call centers on the platform of medical facilities that provide outpatient care. The function of that call center was to accumulate all of the necessary information that was received from the citizens who had problems with going to the hospital, those with comorbidities, those patients who needed adjustments to their treatment plans, prescriptions, automatic writing, the collection information on the inpatient facilities. So calls were made to call centers by hospitals, and hospitals would say that this is the patient XYZ, he was given this kind of treatment, this is the treatment plan, etc. So for this certain period of time, the prescription will last a certain period of time. It was necessary to send an assistant physician to this patient, or the general practitioner to patients' home in order to reduce the rates of infection. We also organized advisory support on how to channel the flows of patients. The offices of narrow specialists were selected who could provide a certain help. The timing of visits were planned, as well as preventive focus was very substantial. So focus was made on healthy lifestyle. Patients could call the call center and ask what they should do in terms of healthy eating, what they should do in certain situations in the period of COVID pandemic. We didn't have lockdowns imposed. All healthcare facilities functioned and operated. All of the facilities worked. Everything was planned. There was a mobile team that worked, that changed the regulations, made changes to various tactical algorithms in various situations. There were some problems in establishing the call center. Initially, availability of information to people. So people had to know that they could call and ask for advice to get adjustment to their treatment plans. Currently, laws on healthcare and telemedicine were amended, and it says that for future consultations, either on the phone or using the information technologies, the primary visit should take place anyway. But in the future, organizations could provide consultations at various levels, from first to fourth level of the organization. It allowed to reduce the burden on general practitioners, more physician assistants, but were more involved, and nurses as well. We used broadly the help of students who had the right to provide consultations to patients in the issues of prevention, on flows of patients, on making appointments with doctors, on prescriptions that were later delivered by volunteers. In some cases, those deliveries did not even take place. People could receive prescriptions to their emails. A patient does not even have to go to a doctor now. He can go to the pharmacy and using his electronic medical record could get the necessary medicines. So about 40, according to our standardization documents, the doctor's visit is supposed to be 40 to 45 minutes. But with the help of various forms of consultations, we could increase the number of patients that could be serviced in this period of time. The Republic of Belarus is now working on improving on upscaling the use of the system. It used to work before, but in the future, some of the issues and how they are worked on in various normative documents, we need to calculate the work burden on the physician. It has to be taken into account because it's a consultation anyway, that it has to be delivered either by a doctor or medical assistant. So, and it needs to be taken into account. Or we have the system of carrying outpatient facilities. A person without medical education can direct and forward patients to the relevant specialists. Thank you very much, Tatiana. It's a very rich experience, and I think all of the countries have very good experience of implementing online consultations. It's very important to systematize our knowledge in such consultations if we want to rely more on digital technologies to understand what factors affect the quality of online consultations. What are the barriers in the implementation of such systems? This is my request. Please do the analysis. Please take records, take notes. We will need it in the future. We will need to reflect your lessons in our future policies. I would like to come back to one of the aspects that was mentioned before, the possibilities for professional growth. I think you talked about how important professional growth is, that financial motivation is not all, but professional growth, possibility of professional growth is important. We heard a lot from our medical workforce why they choose PHC for their future work. So it's important for them to have the possibilities for professional growth. I would like to talk about Tajikistan. Tajikistan is accelerating the strengthening of PHC. In spring this year, I visited your country. We signed a memorandum with all the partners of the Ministry of Health of Tajikistan in order to work on strengthening PHC in Tajikistan together. I'm very pleased to introduce Abdulkhalil Amirzoda, the Deputy Minister of Healthcare and Social Protection of the Population of Tajikistan. Could you please share with us your experience and tell us what is the role that is played by the continuous education in the life of physicians in Tajikistan, and what other possibilities for professional growth are provided to family doctors? Thank you very much. Allow me to thank the Ministry of Health of Kazakhstan for this invitation to the 35th meeting of the CIS countries, Dr. Hans Kluge and our colleagues. At this point in time, I would like to thank you all for participating in this talk show. The primary healthcare is a foundation of the healthcare system in the Republic of Tajikistan. Tajikistan adopted the model of PHC based on the principles of family medicine. Tajikistan invested a lot in training of family doctors and nurses who will provide assistance in accordance with the existing needs. 73% of the population of the Republic of Tajikistan reside in rural areas. Primary health care is the gate for strengthening health of the population. In year 2008, a decree was adopted that obliges the cities and villages to allocate at least 40% of their budgets to PHC. It resulted in increased cost for primary health care. The family medicine was strengthened in the country, and thanks to effective work of the family medicine, the maternal deaths in the country and child deaths went down.
We're clearly seeing the work of primary health care in treatment and follow-up done by family doctors. During the pandemic, the main role for prevention and treatment was played by the family doctors. And currently, only general practitioners and nurses are the ones who help with the immunization against COVID-19, and they play a key role in prevention-related measures for the population. Now, the family doctors, the general practitioners and nurses provide the key services for communicable diseases as well. And the knowledge of family medicine is on quite a good level. The specialists do need, though, further capacity building and ongoing medical training. And just like other countries, the COVID-19 pandemic has stimulated the implementation of digital technology and digital platforms to aid primary health care. The country is implementing a system of ongoing medical training, employing cutting-edge technology to provide the ability to train on the job using mobile internet, and strengthening the facilities and equipment of primary health care is one of the key elements to create a motivating working environment. And we're improving and updating the infrastructure of primary healthcare institutions, renovating the old ones, and building new buildings, regional health centers, rural health centers, and health centers in the cities. Currently, in the country, in spite of the assistance provided, the Republic of Tajikistan and its Ministry of Health have some challenges. A deficit of general practitioners. General practitioners are working in the regions with burdens, and we need an improved staff policy on family doctors. And the country still has experienced and motivated young specialists in family medicine. And we attract them by providing free of charge land plots in remote areas. In the experience of this support over the past years, we've awarded the family doctors with medals and thank you letters from the Republic of Tajikistan and Ministry of Health of Tajikistan, which also is an effective way to fight emotional burnout. Thank you very much. Some really important points there. And I think especially having more family doctors and nurses is the most important thing, right, in Tajikistan? Yes, because more people, a larger share of people live in rural areas. 73, that's the highest share of all the countries participating here today. Yes, they need all the equipment, the facilities, especially in these remote areas, the regions. Yes, and it's a very positive thing that there's now more budget for the primary health care from the local authorities' budget. Now I'd like to move on to Armenia, and thank you very much for your patience. Armenia is developing a new strategy of improving primary health care to make it more efficient, to address non-communicable diseases and also mental health. Artak Jumayan, the Deputy Minister of Health of Armenia, happy to introduce you. What are the strategies that you put into the primary healthcare to attract new specialists into primary healthcare, and how do you plan to create an attractive working environment? Thank you very much. You can hear me, right? Yes, we can. Well, allow me to first of all thank you for the organization of this event, for this good discussion. Dear colleagues, dear Dr. Kluge, I'd like to introduce to you how in Armenia we are doing all of this. After the collapse of the Soviet Union in Armenia, outpatient medical assistance, we never focused on so much as we do now. So we would change here and there some management issues. In Yerevan, in the capital, and in the large cities, we have this classic polyclinic, like an outpatient clinic format, where all of the tests are being done. So that's the Soviet model. And in the regions, in the rural areas, there's more of this family medicine approach. Now, this year, based on the decree of the Minister of Healthcare, we made a large adjustment on reforming primary health care and focusing strongly here on starting from the personnel issues. Having listened to all of our colleagues here today, we have the same issue, this personnel deficit, about 45%. And the age as well, the average age is quite high. The age from 50 to 75 years, that's about 25% of our medical staff. That's a very high share, especially in rural medicine. That's more than 40% of the average age there. So we are focusing also strongly on the infrastructure, building new outpatient clinics, doing renovation in the clinics, new equipment. We're focusing strongly on prevention as well. We have screening programs, but these programs are not too effective in terms of their funding. So we try to fund them a little better to make sure that we also increase the salaries of the doctors who do prevention, because our funding is based on the number of attached population, so it's a fixed salary. And this new system will help remunerate the quality work and KPIs. We're also considering the geographic locations, the terrain, the hard-to-reach areas. So we have paramedic points. And on the third level, we can attach the patients to the inpatient clinics. But here, every specialist will have their boss, and we still try to keep it neutral. Now, a lot of focus is on developing rural healthcare and electronic healthcare. We just had a meeting about that yesterday. We already have electronic patient files. We already have digitization of all the logbooks, the journals, so the doctors are now working with the mouse and not the pen, and doesn't have to input data into several different databases manually. We already have a decree, and we're actively working in telemedicine. So all of these inpatient, outpatient facilities, we will be connecting them with the help of this telemedicine system. And when downloading the app of our e-healthcare to your phone, you can have contact between doctor-doctor and patient-to-doctor. And with the medical institutions in difficult situations for doctors' consiliums, we'll also be using telemedicine. I think briefly that is what we have at this point. So if you have a question, I'm ready to answer. Thank you. Thank you very much. An interesting period for Armenia, developing a new strategy for primary healthcare where you can do it like a comprehensive approach. And now finally, I'd like to invite our regional director for the final speech, the final word. Dear Hans, how can the WHO support the countries to strengthen the staff capacity in primary health care? Now our main task is to support the countries in the European region in their striving to provide the availability of medical assistance for every citizen, everywhere in the country, no matter how remote, no matter how rich, what age, or political views. We always say we leave no one behind, leave no one without medical assistance throughout their whole life. And our approach to primary health care is providing multidisciplinary support to the countries, individually adapted to the local context. Adapting, that's very important. And throughout the year, the WHO primary healthcare team has already conducted 15 missions And I'd like to thank and congratulate you, Melita, because this is also stemming from your leadership, and we're very proud. And I'd like to emphasize once again a big support from the government of Kazakhstan for a primary healthcare office in Almaty. Dr. Giniat, that's wonderful. Now, all of this, if these people have facilitated the dialogue and coordination of international partners in order to achieve the strategic goals of primary healthcare. And only by helping each other and exchanging the different diverse successful experience, we can successfully move forward on the way to retaining and developing medical staff as the key ingredient to reforming the primary health care. The time to act is now, and the WHO is always ready to provide their support. Thank you very much, dear Dr. Kluge. At this, we conclude our discussion today, and I noted for me 3 important things. The first one is that there are no simple solutions. If we just choose one tool, then we can't do it, because you've all talked about a very comprehensive approach, and the holistic approach is the only way. That's the number one thing. And number 2, it's very important that we base and inform our decisions with data. As you said, incentivizing the medical staff. This helps us create more realistic policy, and we don't base our work on stereotypes, which we all have. So we need to invest more into having better data on human resources. In our new report that you can see, it helps a lot in that. And the third thing is that nobody has the absolute one right answer, right? But a lot of us have good achievements and good examples, and this regular experience exchange helps achieve a lot. So I think that today's council of the CIS countries was really interesting, really useful. That's why we've opened this primary health care platform to see how this can work on the spot, on location. So we're waiting for you here in Kazakhstan and then in Sweden in the future. Now, we're ready to support all the countries and work with you. Thank you very much for having found the time today to talk to us today about primary health care. Thank you very much. And I'd like to thank our viewers as well. We had 250 viewers online, and we've got another room downstairs where they're streaming us. So I hope that was useful and interesting for you. And I'd like to thank our host, Kazakhstan, and the city of sunny Turkestan. And hopefully you all have the opportunity to visit the city. Thank you very much, and see you again.